Yeah, it's recording. Let me get the presentation. Okay, can everyone see that?
Yep.
Great. There we are. Great. Okay, so if we make a start then. So good afternoon, everyone, and welcome to our final session of today's seminar. So I'm sure most of you have done at least one session throughout the day, but for those of you whose session is your first one, I'm Richie Lewis. I'm an Assistant National Officer for Unison in the health team. I'll be chairing this session this afternoon with my glamorous assistant, June Chandler, and this session is going to be led by Lauren Walker, who is a professional advisor for the Royal College of Occupational Therapy. And the session is entitled The Role of Occupational Therapy in Addressing Health Inequalities. So Lauren's going to be assisted by her colleagues Jacoba and Liliana for the session. Jacoba is an OT, or an occupational therapist, working in an integrated learning disability service. And Liliana, when she joins us, is a lead occupational therapist in our mental health unit. So as you have been told already, we're recording the session and we'll circulate the CPD certificates for this session in the coming days, and all of the sessions you've attended as well. So you'll get one for each session that you've attended, along with the feedback forms. If you could fill those in and send them back when you get them, that would be really helpful. As we've done for the other sessions throughout the day, you can use the chat box function to raise any questions or comments, or you can raise your hand using the raise your hand function as well. So either June or I will pick those up. I think that's everything from my end for an introduction. So I'll hand over now to Lauren and Jacoba.
Thanks, Richie. Yeah, good afternoon, everyone. It's lovely to be here with you, albeit virtually. So yeah, thanks for sticking with us for the last slot of the day. So yeah, I'm Lauren. My pronouns are she, her, and I'm very happy to be speaking to you all today alongside my co-presenters Jacoba and Liliana. And I've just seen on the chat Liliana has managed to join us, hot-footing it from her training session. So yes, we're all here and ready to go. Next slide, please, Richie. And that the timing of this session on occupational therapy and health equity feels particularly apt, really, because last week was, of course, Occupational Therapy Week, and our theme for this year was OTs for Equity. And there were various events and activities going on, which I hope you were all able to engage with in some way. And the intention really was that the week would act as a catalyst for continued learning and continued action on health equity across our profession. So there are still lots of resources that you can download from the RCOT website. There's a new report that we've published on health equity, and you can also still contribute to the ideas platform that was set up for OT Week, and that actually would be a really great reflective CPD activity after this presentation. So if you're not familiar with that, there's a link through the RCOT website, and it's just kind of an online platform, but it poses 4 specific questions around what is your role as an individual in terms of addressing health equity, what can we do as a profession, what can we do as a college, and also what would we like to be calling upon the government to do. As kind of a caveat around that is we're having some maintenance on the website at the moment, but my understanding is that all the OT Week materials are still available. So yeah, head down to the RCOT website. Yeah, next slide, please. So building on OT Week, our intention today really is to get you thinking and talking about what health equity means to you, and to hopefully give you some ideas for how you might take action to address health equity in your own practice. So we'll talk for about 45 minutes, and then we'll have time at the end for questions and discussion, hopefully. So as Richie says, please do use the chat bar to share any questions or comments or ideas that come to you while we're speaking. I'm going to start with just a little bit of scene setting, really. So thinking quite broadly about what we mean by health equity and health inequalities, and what our responsibilities and opportunities are to act on health equity as occupational therapists. I'll then hand over to Jacoba and then Liliana, and they're going to share their personal and professional reflections on health equity. So we'll be exploring the subject through a few different lenses. And it is a huge subject. There are many, many different ways to approach it, and no one person, profession or organisation can seek to solve health inequalities. But there are different parts of it that we can each attempt to kind of put our arms around, if you will, and take action to address. So with that in mind, the angle that we would really like to take today is to focus on the strengths and the opportunities that we have within the occupational therapy workforce to help us tackle health inequalities. So we'll be thinking about how our diverse personal and professional backgrounds help us to provide the best service to the people who access occupational therapy. But as part of that, we do have to recognise, one, that the OT workforce isn't currently as diverse as it ought to be, and two, that members of our own profession experience health inequalities. So it's not just something that happens out there to other people, it's something that's happening to us, it's happening within our professional community as well. So what opportunities do we have collectively to support and empower our colleagues, as well as our service users? And I hope that's a particularly pertinent and interesting question to you all as BAOT stewards, because as well as being clinicians, you obviously care a great deal about your colleagues. You want your workplaces to be supportive environments. So I think you've got a really interesting opportunity, quite a unique opportunity, in fact, to consider health equity as part of all of that. And Jacoba, Liliana and I hope that our thoughts and reflections will be of some use to you in that respect. Next slide, please. And what do we mean when we talk about health equity and health inequalities? Well, there are various definitions. We could be here all day debating it, really, but I find this just a very brief descriptor from the King's Fund to be quite a good one, quite a useful one. So health inequalities are avoidable, unfair and systematic differences in health between different groups of people. There are many kinds of health inequality and many ways in which the term is used. And this is actually taken from the beginning of a really useful article that the King's Fund have on their website, which is called, very helpfully, what are health inequalities, which does what it says on the tin, really. And it's quite a good place to start, I think, if this is a subject that is quite new to you, or if this is something that you're introducing to other colleagues as well, as quite a new concept. And then the second quote is what we have to say at RCOT. So health equity means fair opportunity to live a long, healthy life. Inequities in health are not inevitable or necessary. They are unjust and are the product of unfair social, economic and political arrangements, which I think really reiterates the point about the differences being both unfair and avoidable, and also about it being something that is both a societal and a political issue. Next slide, please. And why is taking action for health equity something that we should be concerning ourselves with? Well, to quote Professor Sir Michael Marmot, one of the leading experts on this area in the UK, if not the leading expert in the UK, frankly, there can be no more important task for those concerned with the health of the population than to reduce health inequalities. Review what can be done to reduce health inequalities and then do it. Social justice demands it. Morally, ethically, we all have a responsibility to address discrimination and injustice. Speaking very personally, I recognise that I am someone who holds immense privilege in lots of ways because of my background, and I have a duty to understand and address that in my personal life and in my working life. And taking steps to tackle health inequalities is one of the ways, one of the many ways that I can do this professionally, and that we can all do this professionally. Next slide, please. And there are multiple factors that can impact upon an individual's experience of health inequalities. And again, as with the definitions, there are different ways of thinking about this and categorising it. But these clusters, these kind of four broad groups, are one way that they are quite typically grouped together, certainly in the literature and research and reports coming out of the UK. So we know that people from poorer socioeconomic backgrounds experience greater health inequalities, and there is a clear geographical link to that as well. We know that people from certain communities and with certain characteristics also experience greater inequalities, and all of these factors overlap and intersect. So any one individual may encounter multiple different factors that can either increase or decrease their experience of health inequalities overall. which is why localised and personalised approaches to really understand people's lived experience of health equity is so important. Next slide, please. There's a large and an ever-growing amount of evidence and data that demonstrates the prevalence and the impact of health inequalities. And these graphics from OT Week just give a really tiny snapshot of the kinds of disparities that we know exist in the UK at the present time. So it is a society-wide issue that we as a society need to dismantle. But as health and care professionals, we have some quite specific responsibilities, but also some quite specific opportunities to take action. Next slide. And that responsibility is reflected in our professional standards as occupational therapists. So section 3.3 of the standards addresses our responsibilities in relation to diversity, equality and sensitivity. And it talks about advancing equality of opportunity for all, which is something that I just want to unpack a little bit, because I think it will be helpful, hopefully, in framing the rest of what we want to say to you today. Next slide, please. Because when we talk about equality of opportunity, it doesn't necessarily mean that we treat all of the people who use our services in the same way, because that assumes that everyone has the same needs and the same advantages at the outset, when actually we know that some groups and communities are systematically disadvantaged. And so treating them in the same way as people who don't experience that disadvantage will only continue or even widen the health inequalities that they already face. So rather than our approaches being equal, meaning the same, they need to be equitable, meaning that everyone gets the type and the level of support that they need, and that those in greatest need get the greatest support in order to reduce the existing systemic inequalities. And I think this illustration by Matt Kinsella is a really nice visual representation of that. Though I would caveat that by saying that it's not just about the amount of resources that each community gets, it's about making sure that they are the right type of resources and tailoring services so that they are appropriate for the people that they serve, which is something that very much fits with the core values of occupational therapy. Next slide. And as occupational therapists, we have lots of opportunity actually to have impact upon health inequalities, because no matter our area of practice, we work with people who are affected by health inequalities every single day. And our whole professional rationale is about identifying individualised approaches to support people to overcome barriers in their daily lives. So we work with people from inclusion health groups. So we work in prisons and in forensic settings. We work with people experiencing homelessness and with refugees and asylum seekers. We support people with protected characteristics, so members of the LGBTQIA+ community, people who are disabled, people of all ethnicities, people of all ages. And sometimes this is in services that are specifically designed for certain groups, but a lot of the time it's not. So we need to make sure that all of our practice settings offer equitable services to diverse populations. We work in urban and rural locations and in economically deprived areas. We work in housing and in employment and education. And all of these things are intrinsically linked to people's experience of health inequalities. And in terms of how we work, not just who we work with or where we work, we pride ourselves on considering people in the context of their environments and their occupations. We really look at people in 3 dimensions. And not only do we help people to manage and recover from existing health conditions, but we also work to prevent ill health and loss of independence. So in short, we're not lacking in the opportunity or the skills to really make a difference to people's experience of health inequalities. And as I said right at the beginning, that's not just about looking outwards towards the people who use our services. It's also very much about supporting ourselves and our colleagues so that we can all thrive in the workplace. Next slide. And it's a huge and it's a complex subject, and it can feel really challenging to know where to begin. Oh, the slide's been a bit wonky. Was Richie frozen? Oh no, I think Richie might have frozen. Oh, there we go. Yay! Time lag. But I think the best advice really in terms of where do you start is you start with yourself. And earlier this year, the King's Fund published a framework, there we go, for allied health professionals to help them consider their role in, or our role rather, in tackling health inequalities. And the framework talks about taking action at different levels. So starting with yourself as an individual, then thinking about the people that you work with in terms of your patients and service users, then yourself as part of a team, part of a service, the communities that you are part of, and then the wider systems that we all sit within. And it's important to start with ourselves because we all have different experiences and ideas that we can bring to the table when we're thinking about the opportunities for tackling health inequalities. And I really urge you to take a look at the framework. I think it's a really practical, kind of a very useful document. And I also urge you to continue a dialogue about this with your colleagues. So this isn't just work that you need to do in isolation. Talk to people, share those thoughts and ideas, and not just colleagues from our own profession or your particular area of practice, but colleagues from completely different areas of practice as well. It's all useful, really useful learning. Next slide, please. And when we move from thinking about ourselves as individuals to considering ourselves as part of services and systems, there are three kind of quite broad questions, these three broad questions here, that I think that are really quite important for health services to ask themselves when considering their impact on health equity, because we know that some groups and communities are less likely to be in contact with health services and are also less likely to have a positive experience of health services when they get there, and reduced outcomes. And the reasons for this are very multifaceted, but I'd like to just share one case study with you, which gives a really practical example of the kinds of steps that an occupational therapy service can take to identify and address barriers to access and experience, and also how the makeup of this particular occupational therapy team was a real asset in bringing about a positive change. Next slide, please. So this is a case study, when it appears, that was submitted to the RCOT Small Change Big Impact Story Wall by Gulshana Kadir. There she is. And Gulshana says, in Tower Hamlets, 1/3 of the population is Bengali. Our team believes that parental engagement and collaboration with parents is key when working with children and young people. Language was a barrier for Bengali speaking parents to engage in our parent workshop. A Bengali speaking workshop was set up by our Bengali staff to run alongside our English workshop. Recent feedback highlights that parents value the opportunity to share and feel connected to others and to problem solve together in Bengali. Attendance rates increased and Bengali families attend consistently. Parents who have attended have a greater understanding of our role, report increased parental engagement and self-efficacy, ultimately improving outcomes for children and young people. So Gulshana and her team have recognised the needs of a particular community within their local area. They've recognised the existing barriers to this community being able to access their service in an equitable way. And they've proactively taken steps to change that, which has improved access, it's improved experience, and it's improved outcomes. But what I particularly wanted to highlight in Gulshana's example is that having diversity within their own workforce was extremely valuable in helping to address the inequalities being experienced by their service users. And we know that diversity is an issue within the OT workforce currently. We have a very high percentage of white women within occupational therapy, which doesn't represent the diversity of the people that we serve. And that balance really needs to shift, which is something we've begun to address at the college. But we all have a responsibility to champion diversity within the workforce by supporting colleagues and students and apprentices from all backgrounds. Next slide, please. And just finally, before I hand over to Yakoba, I wanted to finish with this quote, which comes from Dr. Bola Owolabi, who is Director of Health Inequalities at NHS England and Improvement. And I'm blown away every time I hear her speak, or whatever she's speaking on. But this is from a podcast that she did with the King's Fund earlier this year, which you can still access through the King's Fund website. And Dr. Owolabi says, the 1.3 million people that are employed by the NHS are a microcosm of the wider community. As we look after our staff and address their health inequalities, that is us putting our house in order as we then look after the rest of the community. And if that's true of the NHS, I would suggest that it's also true of social care services and the wider health and care system generally. So my final thought is, what part can we all play in addressing health inequalities, not just through our clinical practice, but through our interactions with our OT colleagues? And on that note, I'm going to hand over to Jacoba.
Hi. Can you hear me clearly? I haven't got
much. Yeah.
So sometimes I'm known to speak a little bit quiet. So if I'm going quiet, just up me a little bit. So my name is Jacoba Banks. My first name is actually Rebecca, but my middle name is Jacoba, and I prefer to be called Jacoba because I think it reflects me. Very often I went for interviews as Rebecca Banks. I turn up and they thought, oh gosh, she's not a white woman. So very quickly I diverted to calling myself, I've always called myself Jacoba. So I work as an occupational therapist in an integrated team in East London. And I'm working with adults living with learning disability. So I do like working with people very much. But I've chosen to speak about two groups of people that I'm quite passionate about. One being adults living with learning disability, and the second group being Black and ethnic minority. I know the second one is large, but as we get along, we'll probably see why. So we've heard what Lauren presented about health inequality, so I'm not going to bore you at all with what it is and what it's not, as we all know. Instead, I'm going to tell you a story.
Jacoba, just before you launch into your story, just a reminder, just let Richie know when you want the slides moving on.
Okay, yeah. So second slide, please, from my pile. Yes, thank you. So this is the story of a lady I have called MK. It's not even her initials. I'm taking out all details to protect her identity because of the nature of this story, because it's real. So this lady was referred to our team because she was having false behaviors of concerns that involves banging her head on the wall and refusing to go into the shower. And although this referral was received in the height of COVID, due to the severity of it, I did a telephone screening and I decided it warranted me going out to actually see her in person to see what we can do to decrease this occurrence of the behaviors of concerns, the refusing to have shower, and actually lack of sleep as well. She was walking around all night. So I did a personal visit. I had to don up due to COVID, completely covered, but I went to see her in person. And she wanted to hug me. It was very difficult, but I had to say, no, don't touch me because of what was going on. But she was really lovely, really took to her. So she's living with learning disability, which is associated with behaviors of concern, nonverbal communication, but she was also living with Down syndrome. She was in her 50s. So during the visit, I assessed her bathroom and looked at different things, why she wouldn't go in the bath, and realized that she couldn't bend her leg to even get over the door lip to get in. I made a further recommendation to the housing team and the repairs team for the bathroom to be altered. But we had a very long chat because it was the first time that they've seen anyone on the premises in a care home for a long time. So during the chat, I said, and what's about this head banging? They said, oh, she used to do it, but she stopped. But she had some type of seizure. And after the seizure, she started banging her head on the wall again. And they asked if I could put cot-side on her bed to stop her from getting out of bed. And I advised appropriately and said, no, she would climb over it. It would increase the risk. And we talked about it. But I said, what have you done about the head banging, holding her head, not one sleeping? We've referred to the doctors. The doctors has referred further to a neurologist. To cut a very long story short, the neurologist got a letter, did the phone screening, did not examine her physically, did not send her for any scan, but wrote a letter to the doctor saying she's in her 50s, she lives with Down syndrome, she is got learning disabilities. She's been banging her head on the wall. Increase her sleeping tablets so she can sleep and have rest at night. Hopefully, it will decrease. So after the bathroom was done, I picked up the phone to call, only to find out that MK had passed away. I'm really sorry to tell you a very extreme and sad story. But this is the reality for some people living with learning disability. This is uncomfortable for us to hear, but this is the uncomfortable life that in the UK today, some people experience. This is real. This is a real story. This is a real human being. This is someone I saw. So this is the picture of health inequality amongst a lot of people living with learning disability. There is high prevalence of comorbidities such as Down syndrome, ASD, behaviors of concern, which sometimes arrogantly got written down as a diagnosis. No, it's an association of different things. I think we've got a hand up. Shall we pause?
Yeah, sorry about that. Yeah, I'm just wondering, like when you say she's passed away, how long it took to get the bathroom done?
Oh no, the bathroom was done not too, it didn't take too long at all. The bathroom didn't take too, and she didn't fall. It wasn't from a fall. So she passed away. I must clarify that she passed away and they realized that there was a cyst on her brain. I guess if there was
medical
a scan
condition
and a physical examination, that could have been identified. I know that there was COVID around. I know services were stretched and different things was going on. And I'm not even speculating that it would have changed anything.
Right, okay, thank you.
So a lot of people living with learning disability have mental health issues as well. They live with loads of it, and they live with a lot of behaviors of concern, which in itself can lead to accidents and untimely avoidable death as well. People living with learning disabilities have worse physical and mental health than the general population. So I'm going to bore you a little bit with statistics. Just give me 2 minutes to be a little bit boring. So women living with learning disabilities have 18 years shorter lifespan than the general population. When it comes to men, they have 14 years shorter lifespan, or life expectancy, I must call it, than the general population. And in 2018, there was a mortality review by LEADER, and they found an average mortality age to be 59 amongst women living with learning disability and 60 for men, as compared to 86 in women in the general population and 83 in men in the general population. So there's a difference of 27 and 23 of years of life expectancy, and that is really huge. It's quite vast. 23 years. You and I could do a lot with that. So the level of learning disability also widens the gaps even further. So again, in 2019, LEADER again, or LADDER, some people call it, did a review and found that the gap between adults living with learning disability, mild learning disability, had a life expectancy of about 62, but those with profound and multiple learning disability, it was 40. That's just staggering. They also found out that out of 112 people in their study, 19% of the deaths were actually avoidable. They gave a definition of avoidable death, but I won't bore you with that. So enough statistics now. So people living with learning disability often experience inadequate care due to lack of understanding of learning disability amongst the general population. very often when they go into hospitals and we are supporting them in hospitals, we find that the service that they get from the hospital, if they are not on a specialist learning disability ward, the nurses do not understand them. The behaviors of concern due to frustration, lack of communication is seen in so many ways and misunderstood. And there is actually a program going on at the moment called STAMP, which is where a lot of adults living with learning disabilities were being given antipsychotic medication when they had no mental health diagnosis. So there's a big program going on to take people off antipsychotic medications and in fact involve people like psychologists, occupational therapists, different people to deal with the holistic, given a different approach than the medical model of medicating them, people who didn't need medication. There is often also transitional difficulties as well. So people with learning disabilities might transition from children's services, and a lot happen at children's services. They give them quite a lot and a lot of attention, and it's better than adult services. So they turn up, they grow up, and families feel like they are suddenly left alone. So the next slide, please. So I'm an occupational therapist working in an integrated team. This is my role. I've decided to go alongside the awareness, the role that RCOT highlights. So awareness, what is my role as an occupational therapist? Is to become aware the impact that learning disability has on people's daily lives. And to really educate myself and other people around us. Sometimes when I go to see service users in care homes, I tell the carers, you do understand that this person is not behaving this way because they want to. There is a reason. You know, and I've encouraged many care homes to get training, to get a deeper understanding and become more aware of the client groups that they are actually working with. My actions, so how I work as a part of an integrated team to look at a client in a holistic manner is very, very important. It's critical to my role as an occupational therapist. So we have a physical health team, which mental health comes underneath it as well, which is absolutely brilliant because we have psychiatrists, psychologists, behavior therapists, specialist learning disability nurses, occupational therapists like myself, nursing, physios, and many more that we have on the health side. But we work very closely and we sit in meetings every day with social workers, because without them, we cannot provide a holistic approach to providing care. And when we sit in our meetings and I go to see someone and they need a physio, I don't have to wait a very long process. I can just pick up the phone, send a form, and then the case will be picked up. So advocacy. For me, I feel my role as part of, providing all the equipment and doing everything else that I do, a part of my role is to be a voice for adults living with learning disability. When I had to be involved in the leader review for MK, I asked myself many questions. I asked myself things like, could I have encouraged the care home to insist on a physical examination and a scan? Could I have done that? Could I have called them and said, have you got a scan? Have you seen the neurologist? Would I have given her just 2 more years, 1 more year? Could I have advocated more? I learned a lot of lessons from that experience, and I keep learning. So next slide, please. So I'm going to look at the next group of people I chose to emphasize on. So there is inequality within ethnic minority groups. And the picture is actually a very complex, and understanding it is also very difficult because there is lack of good quality data. So on this particular group of people, I'm going to emphasize on the poor experience of health service that people of ethnic minority groups tend to face. So next slide, please. I'm going to tell you another story. This is not a sad one. I'm going to make this one not a sad one. I was working on a ward that treats oncology patients. There's a lot of people that gets admitted onto this ward due to sickle cell anemia, a condition that a very few population in England live with because it's very prevalent in West Africa and some parts of India and very some parts of the Caribbean. A lot is not known about sickle cell anemia. The only reason why I had a lot of knowledge of sickle cell anemia is because I come from West Africa and I had family members. In fact, my mom is a carrier of sickle cell. So I knew a lot about it. I saw so many people dying, going into crisis, what they call crisis. So I was working on a ward and there was a lot of sickle cell anemia patients on this ward. There was a particular lady I would call AJ. So AJ's chicken story. Occupational therapist went to see AJ and said, it's time for you to go home. We've done all you've done, we can do for you. You've had your blood transfusion, you need to go home. She said, I can't look after myself. I'm really struggling. I need extra care. I need some kind of care to help me look after myself. So the occupational therapist said, okay, we will put 2 hours of care in. They will come and help you to shower. She said to the occupational therapist, I don't need help to shower. I can do that. And I've proven that on the ward. But what I really need help to do is especially when I'm in crisis, my joint hurts. And this is a symptom of crisis for people with sickle cell anemia. And I can't cook. So the occupational therapist said, it's a very simple problem. Just buy ready meals. She went through the roof. And she didn't understand why she had such a reaction to eating ready meals. You know, she came downstairs to the office and we had a chat about it. And then I thought, oh, this is interesting. So long story short, after many meetings and talking, I said, perhaps we should think about giving her care for actually food preparation, because that is what she wants. She doesn't want someone watching her. She's 26 years old, having a shower. She doesn't need it, but she needs the care. We called the agency and said, we haven't done this before, but I'm sure we can do it because we've done it for elderly people. She got tailor-made, person-centered care that helped her to prepare her meal. There was a cultural implication with this. Cooking for her from her culture was a very important thing to her. Seasoning her chicken seemed very trivial to the OT, but it was very important to AJ. So there was a lack of person-centeredness in this care. But with a lot of deliberation, we were able to give her exactly the package of care that she wanted. She later on actually said to me before she left the ward, thank you. She said, I've been on this ward so many times, and every time they give me carers to come and help me to wash, and I get rid of them because that is not what I want. Further on to that, we actually went on to do sickle cell anemia training so that all the staff and everybody on the ward would have a deeper understanding into this condition that a lot of people came on the ward with. So this is where I then talk about in representation. Perhaps I was able to bring my experience, my knowledge of sickle cell anemia, and maybe it was just one person, but it led to training. It led to a wider awareness and understanding of a condition that so many OTs were dealing with, but lacking understanding. Next slide, please. So my role as an occupational therapist. So I bring a unique lived experience as a Black woman into a profession that is not diverse at the moment. It's getting there, it's doing really well, but it's not diverse. But I have a lived experience that I can bring as an occupational therapist from a Black and ethnic minority background. I also try in the communities that I work to understand cultural perspectives and how important it is to the person that I'm actually caring for. So when I think of my awareness, I think in practice, I need to reflect on how much I know of the group of people that I'm actually working with, be it LD, Black and ethnic minority, Bengali, whichever group I'm working with. How much do I know? I need to reflect on that. And in that, I can then lead on to how much I need to know to be able to provide person-centered care. In my actions, I need to reflect on what I say, how I say it, the implication, how it's received, and what I can do in the short and the long term. Again, I have a role as an advocate, and my role is to champion, to meet the needs of different groups of people, different communities and population. Next slide, please. So in my practice, I need to be flexible. I need to change my approach to my assessment. As most of us are aware, most occupational therapy practice and modules can be quite Western centered. And so I need to be able to change my approach, do it differently. I wrote an article for the Occupational Therapy, RCOT publishing. And I wrote about how I was actually one day able to do an assessment in a completely different language. I speak a few dialects, and I was able to do that. And the reaction the lady gave was, I just feel so understood for the first time. And it made me think I, as a person, have a unique role to play as an occupational therapist. I have something to bring from my background, from my lived experience, from my culture. And I also need to be sensitive to cultural issues as well, like the story of AJ. Next slide, please. So I always reflect on developing myself to gain greater insight into my values, my strengths, my unique contribution in providing health. And by doing so, I can be a part of reducing health inequality in England. I need to continuously explore and reflect on my implicit bias and unconscious bias and how it impacts on my practice. So finally, I shall end with, policies only become reality when professionals in close contact with service users continue to be curious, to learn new things, seek new knowledge, reflect on practice, and become proactive in seeking change. And I think we are all in that position. Thank you.
Thank you very much, Yukoba. That's an excellent presentation. I'll step in for Richie here because he can't actually see the chat or anything, but we've had a reaction while you've been talking from one of our delegates, Debbie Riley, who was quite shocked at you. I mean, I must say I'm glad you did a happy story as well as a sad one, because they're both extremely powerful case studies. But Debbie was saying how, agreeing with you, that how all assessments should be needs-based, not based on age or culture. And there's lots of learning that we can take from your presentation. I think given the time constraints, should we move on to ask Liliana to give her presentation? Hopefully there'll be some time at the end to get contributions. Thank you.
Hello, everyone. I am sorry I come out as carer support on my screen. I don't know how to change that, but my name is Liliana Mandel, short for Lily for short. I'm the lead occupational therapist in an adult acute mental health unit in North London. Can we go in the next slide, please? So today I'm just going to talk about really my experiences as an occupational therapist working. Sorry, I'm just been in an away day, and I'm actually sitting in a pub, and I'm just gonna change area because sorry.
Just while Liliana's relocating herself.
I'm really sorry. It's just that I did not have any other place to go, but now I'm here, so it's going to be a bit noisy. So bear with me. So really sorry about this. Okay, now I'm by myself, so it's fine. So yeah. So I was saying that I just wanted to talk about today about an article that I've written for OT News. And that was
Have we lost Liliana?
Oh no. Oh, poor Liliana, she's trying so hard to join us. I'll have to complain to whichever pub she's in. While she's sorting herself, I'll give a little bit of background, because that was part of the reason why I reached out both to Liliana and Jacoba, was having read the articles that they both wrote for OT News. So Jacoba spoke a little bit about hers, which I think was August this year, and Liliana's was back in July. And Liliana wrote really kind of powerfully, I thought, about her experience of being an occupational therapist who has both dyslexia and dyspraxia, and she was reflecting on the experiences that she had kind of throughout her occupational therapy education, and then going through into the workplace, and the kind of support that she received along the way. Is she rejoining us? I'm not sure she is. Is she? Oh, she's leaving and coming back again. Do you want to flick on to the next slide, Richie?
Yeah. Okay.
And I'll do my best to kind of paraphrase some of the discussions that Liliana and I have both had. I can't talk about her baby photo, as cute as it is. But yeah, Liliana is now a lead occupational therapist in a mental health trust. And I know she said in her discussion with Jacoba and I, when we met up to discuss this presentation last week, that, you know, if you'd said to her before she embarked on her training that she would be in the professional position she is now, she would have struggled to believe you, because she'd been kind of led to believe sort of along through her life that having dyslexia and dyspraxia would be something that very much held her back. And, you know, she's not had uniformly excellent experiences of support by any means, but she has at key points in her professional development has had really good support from university lecturers, from her practice educators, and then from her colleagues now that she's gone out into professional practice. So I think the message that we sort of wanted to get through today is that, you know, it isn't just about looking out at people who are using our services. It is thinking about who are our colleagues, what kind of support might they need, because that richness of background, that richness of experience helps us all to be a better profession. She's back.
Sorry, I just got disconnected. It all went wrong. I had a really nice spot, and then so forgive me. I'm going to start again. So yes.
Liliana, I've done them just in the interest of time, because I think we are going to run out of time, I think. And just to say, if anyone has any questions, I've put my contact details at the end of the presentation. So please get in touch if there's anything that you want to ask either myself or Jacoba or Liliana. Liliana, just while you were setting yourself up, I'll give you a little bit of the background. So around your OT News article. So if you want to kind of skip beyond that bit, that might be a good place to pick back up from, if that works for you.
Okay. Yeah. So today I just wanted to, if we can go to the next slide. So in July 2021, I've written an article building on solid foundation. And the reason for writing this article was part to do with the, the OT equity, OT for equity, part of the OT week. So if you can go for the next slide. So the reason why I've written this article is I wanted to share my story. And this is a really beautiful phrase, because when a flower doesn't bloom, you fix the environment in which it grows, but not the flower. And that's what happened to me. I was a bulb, I'd say. I never really had that nurturing environment where I could grow as a flower. And through my experiences in my working environment, I was able to grow and bloom. If we could go to the next slide. So I'm just going to briefly say my story. So I already said who I am. I already said where I work. I have a disability. I have dyslexia and dyspraxia. And actually, I think it's more the dyspraxia side of things. I really struggle. I struggle through all my life since I was a child, and I was always the last in school. I was always struggling for reading, writing, organizing myself. And everybody always said you would never go to university, you would never be. I always wanted to help other people. And I knew that in my heart that I wanted to do a job that could help others. But I was always told, no, you would never be able to be a healthcare professional. You don't have the brain for it. And that was actually really like a sort of self-fulfilling prophecy. I really believe that. So if we go to the next slide, I'm not going to go into details of what is dyspraxia and dyslexia, but basically on the right hand side that you see here, that's what I see on a daily basis on a screen if I don't have the proper equipment, if I don't have the proper screen, and if I don't have the proper software. That's how much I struggle when I have to write reports, when I have to read things. If we could go to the next slide. In terms of dyspraxia, I'm not going to tell you, you're a healthcare professional, you can look it up, but basically I struggle through all my life, organizing things, playing ball games, learning how to drive, especially spatial awareness has always been a real issue for me. It shows you today how disorganized I am with all how much I really struggle with technology as well. So if we can go to the next slide. So why I wanted to share my story. I want to share my story to OT News because I believe that I struggle with my disability probably until my second year as an occupational therapy student. And that was at the age of 30-year-old. That was quite 30-year-old. I wasn't like a teenager, or in my 20s I was an established adult, and all my life I struggled. I did all certain jobs. I did work in retail, administration, in bars. I work everywhere, and I always struggled. I struggled to maintain like orders, organizing myself. And when I started my occupational therapy degree, my first placement was actually really hard. And in that same year, I went to work as an administrator for an occupational therapist in a pediatric department, and that job was a disaster. And in that job I was told, you're not gonna, can't really do occupational therapy, you're not gonna be able to do this. And I was so blessed to have a tutor that recognized my difficulties and asked me to do an assessment. I went to do an assessment, and in my second year I went to do my second placement, and I remember till this day is I met this very special educator. Her name is Anna, and I'm sure she won't mind to say her name. Her name is Anna, and she literally gave me, she said, "You are my first student, you know." And when there was 2 students to choose, I choose you because you have a disability, because I could see on your paperwork that you have dyslexia and dyspraxia. And I struggle all my life with these disability, and I want to give you an opportunity. And this educator was the first person who gave me that chance to really, like that soil that we were talking about, that, you know, like when we were talking about the environment where the flower can grow. She was the first person. She gave me so much in that placement that it was unbelievable. And that was where I started to build my solid foundation. That's why I call my article that. And when I left that placement, she said, please continue to build in this solid foundation. And I build there. Since then on, I start to build. I also then wanted to share this article to raise awareness of neurodiversity, to raise awareness about hidden disability like mine, and also never to give up hope. And always to remember there will always be someone there that believes in you. If we can go to the next slide. So I receive a lot of support. As I said, the first person who helped me out was Anna. And then from then on, I had amazing educators. I had a lot of support from my family. My husband is an occupational therapist himself, and he had so much patience, and he put his OT skills on me, and he taught me how to drive. He taught me how to manage mathematics and all things, and reading and all sorts of things. So I had so much support from family, especially employers as well. I had a lot of support from my employers. I would never thought I would be an occupational therapist. I would never think I would ever be a healthcare professional, let alone become a lead occupational therapist and manage a team of 6 occupational therapists. And if we could go to the next slide, please. Thank you. Yeah, is because as I said in my article, I felt like I was being at the edge of a pool. I used to know how to swim, but I required that encouragement to jump into the water. If we go to the next slide, please. In my work today and in my work throughout, and how I develop in my probably about 7 years now, I'm an occupational therapist. What really, really helped me was provision of regular high quality supervision, that space where you can find really that can help you to reflect on what you're doing, and you have someone that gives you feedback, constructive feedback, and that's really important. If we could go to the next slide, please. Thank you. I put the picture of scaffolding because for me, having colleagues, managers behind me, that keeps me going. That scaffolding is so important, and that is really what helped me to thrive. If we could go to the next slide, please. And most important of all is the precious gift of time. If we're talking about OT, about equity, one of the things that I really believe is really important is that time that we give to our colleagues, to our patient. We are all rushing around in this world in a million miles an hour because we're so busy, we're stretched, but actually giving that precious time is so important, and that's what I received, and I'm really grateful for that. If we go to the next slide, I know there's gonna be, I put question, but maybe you're gonna have question after. So this is me really in a nutshell. Is it possible to go to the next slide? would like in this presentation to say thank you to the whole acute service team in my hospital. I also would like to say thank you to my manager and deputy director of our borough, Gail Barrell, because she's been amazing. She really saw my potential, and she's the one who encouraged me to apply for a band 7 when I felt that I was not ready whatsoever. To my lovely colleague, Dr. Faye Nikopashos, because she's also been an incredibly an amazing mentor. And to my lovely OT team, because they have to put up with me that I'm quite disorganized and have a lot of, my disability comes out every day. But everybody has given me this time. So I really wanted to thank you all for inviting me today. I do have a lot of strategies that I've learned throughout the years to support myself, with dyslexia and dyspraxis. If you have any one of you has these difficulties, or if any of your employee has these difficulties, I'm really happy for anyone to, Lauren can share my email afterwards. I'm really happy for you to get in touch with me and give you advice or support you. I'm really happy to do that. And yes, sorry about all the the connection problems and being in I just really wanted to make it today, but I was in the whole day in an away day, and I really tried to find this space to talk to you. So thank you so much for having me here, and I'll give it back to Lauren or to whoever's chairing. Thank you.
Thank you, Liliana. I guess the good news about you being in a pub is that now you can just go and have a nice glass of wine. But yeah, just to reiterate, thanks ever so much for having us. We were really grateful to Richie and June for inviting us. Ironically, the precious gift of time is the thing that's run away from us. So, and it is the end of the day, so we won't keep you any longer. But yeah, if you do have questions or you want to get in touch, my contact details are on the slides that we're happy to share with you, and then I can link you in with your Cobra and Liliana, kind of as appropriate. In the slide deck as well, there's quite a few additional slides with loads and loads of hyperlinks and resources on there that we hope you all find useful. So thanks very much for having us.
Thanks very much, Lauren. That was great. Thank you all for that presentation. It was amazing. There was so much stuff in there, and you could see as well in both Jacoba and Liliana's examples about how much your diversity adds to the profession through your lived experience, and how you're able to advocate better for your patients because of your own experiences and background. So it's amazing to see that what we're speaking about is actually being done and lived through in your practice as well. So that's fantastic to hear. Shocking at the same time that we talk about person-centered care all the time. It's a phrase that we repeat often, and yet still people need to be reminded of actually what that is in reality when you're actually at ground level delivering care. So lots of information that's useful. I will circulate all of the presentations to you and to all delegates in the next couple of days as well. So thanks for allowing us to share that, Lauren, Jacoba and Liliana, and for sharing your emails as well. So that's great. All delegates should have my email address as well as June's. So if you want to get in touch either through those email addresses or the BAOT steward's address to try and get in contact with any of our presenters today, then please do so. Thanks very much all for attending and for sticking with us past the finish time as well. Hopefully next year we'll be back to a physical event. We do have it provisionally booked in, and hope to see you all there next year. And most of you I'll see next month. Both June and I will see you next month at our panel meeting. And yeah, before we wrap it up, has anyone got anything that they want to add before I just close the session?
Just to say thank you from my perspective. It's been a brilliant session and really inspiring and moving. So I've really enjoyed it. Thank you to the presenters, and thanks for everyone for coming along.
Yeah, great. Thank you. And I'll share that King's Fund Health Inequality Framework with your presentations as well. I think that might be useful. So thank you, everyone, and take care, and see you all soon.
Bye,
Thank
everyone.
you.
See you later.
Bye.
See you soon.
Bye.
Thank you, everyone.